I'm going to discuss lateral tendinopathy or tennis elbow. Prior to discussing causes and symptoms, it's first important to recap on anatomy. As demonstrated in the image below, the extensor muscles attach primarily to the lateral epicondyle of the humerus via the common extensor tendon. Superiorly on the image, you have ECRL, which primarily attaches to the humerus via the lateral supracondylar ridge of the humerus. Next is the ECRB, attaching via the common extensor origin, the EDC, and finally the ECU. The ECRB is commonly thought of as the most affected, likely due to its close proximity to both the annular ligament and the lateral collateral ligament, meaning there are increased shearing forces on the tendon on the forearm rotation movements. Lateral tendinopathy is a common condition. It affects 1 to 3% within the general population on an annual basis, therefore having a large impact on individuals and society. It is most predominant in middle-aged individuals. Lateral tendinopathy is generally an overuse injury caused by repetitive actions or prolonged manipulation of heavy weights. Common signs and symptoms include pain, which is generally located just distal to the lateral epicondyle of the humerus, and reduced strength. To assess for lateral tendinopathy, you can palpate the lateral epicondyle and into the extensor muscles, and the patient will be tender in this area. There are also several clinical tests which can be used to look for lateral tendinopathy. These tests are all looking for pain provocation as a positive test. So there's Cozen's test, where the patient's forearm is in pronation, the wrist in radial deviation, and the elbow bent to 90 degrees. You'll then palpate the lateral epicondyle and resist wrist extension. The next test is Maudsley's test. The examiner resists middle finger extension whilst palpating lateral epicondyle. And lastly, there's Mills' test, where the patient is seated with the forearm at their side and the wrist pronated, and the examiner passively flexes the wrist while in pronation. A study by Bissett et al., published in 2006, has shown that physiotherapy combining elbow mobilization with exercises has a superior benefit versus a wait-and-see approach at 6 weeks post commencing treatment, and superior benefits to corticosteroid injection after 6 weeks. Corticosteroid injection was shown to have very good short-term relief. However, these were basically reversed after 6 weeks with very high recurrence rates, leading clinicians to consider this as a treatment strategy with caution.